Thank you everyone for joining. My name is Shader Reyes, and this is DMC Medical Group Heart to Heart webinar series. We come to you every month with a new topic related to cardiovascular disease, whether it's a treatment or a condition or something that's happening contemporary now, and especially in the pandemic of COVID-19. We'll come to you with updates and speaking to experts in the cardiovascular space. Today, our webinar title is Type A Aortic Dissection from ER to OR. Let me first introduce our panel is Dr. Kenton Zer. He is the Director of Cardiovascular Service Line at Detroit Medical Center. And our guest speaker today is Dr. Yusuke Terasaki. He is cardiovascular surgeon at DMC. His practice is at Harper as well as Huron Valley and Sinai Grace. And myself, Shader Reyes, I am an interventional cardiologist here. We are coming to you live from Detroit Medical Center. This is the heart of Detroit. We are based on 311 Mack Avenue. It's a one heart space for all care. We have clinics on the 6th floor, also testing happening on the 2nd floor, non-invasive, OR happening in Harper as well as the cath lab. With that, I'd like to start with the opening video to the panel as well as the audience. Again, today our speaker is Dr. Yusuke Terasaki. He is a cardiovascular surgeon and going to speak to us about type A aortic dissection from ER to OR. He has done a number of aortic dissection at Detroit Medical Center since he joined almost 2 years ago. And he will tell us about his experience and how to prevent it and how to manage it.
Thank you for having us, Dr. Zera and Dr. Reyes. And this lecture is more directed towards the internal medicine doctors, the ER physicians, who are on the front lines, seeing these patients and diagnosing type A dissections in the first place. And this is one of the opportunities where cardiothoracic surgeons and the ER and the internal medicine doctors crossing paths. So I wanted to discuss a little bit about the management of this pathology. I have nothing to disclose. I want to time slip about 240 years back. And this is a quote by Frank Nichols, who was King George's personal physician. And I quote him, "On the 25th of October, he rose as usual at 6. This is 6 a.m. and drank his chocolate, for all his actions were invariably methodic. A quarter after 7, he went into a little closet," meaning likely the toilet. "His German valet de chambre in waiting heard a noise and running in found the king dead on the floor." So the same physician, Frank Nichols, was entrusted then to conducting the autopsy of his own king. And this is the description of what he had found. "The pericardium was found distended with a quantity of coagulated blood, nearly a pint. The whole heart was so compressed as to prevent any blood contained in the veins from being forced into the auricles. Therefore, the ventricles were found absolutely void of blood. And in the trunk of the aorta, we found a transverse fissure on its inner side, about 1.5 inches long, through which some blood had recently passed under its external coat and formed an elevated ecchymosis." And this is quite amazing description of a type A dissection that was done 250 years ago. And that's why I wanted to bring this up. Now I'm going to time slip about 100 years later. I'm not sure if you guys know who this is. His name is René Laennec. He was actually the physician, the French physician who discovered the stethoscope. But he also coined the term dissecting aneurysm back in 1819, despite his co-Frenchman Jean-Pierre Manoir, who had already correctly described this condition as aortic dissection 15 years back. And because René Laennec had coined this term as a dissecting aneurysm, until this day, today, we still have a lot of physicians kind of having this misunderstanding that all dissections come from an aneurysm. It doesn't have to be. And then we time slip another 100 years or later on July 7th, 1954. I'm not sure if you guys are familiar with this physician, but he is Michael DeBakey. He's the father of basically cardiac surgery. All cardiac surgeons know him. And he performed the first aortic dissection repair on that day. And then he himself ended up with the type A dissection at age 97 and had a repair by one of his colleagues and survived and lived another year or two later after that.
And Yusuke was actually one of his own trainees, Dr. George Noon, that fixed him.
Got it. In discussing type A dissections, we have to discuss the proximal aorta, the anatomy of it. And as you can see, I'm not sure if you can see my mouse, we have to talk about the ascending aorta, which arises from the base of the heart. This portion is the ascending aorta where the coronary arteries arise. And then you have the arch of the aorta, where the innominate vessel comes off of, and the left common carotid and the left subclavian comes off. So there are usually 3 orifices that come off the arch and then end into the descending aorta. Now, the reason why I bring that up is because not all patients have 3 orifices inside. If you see in the diagram labeled D, this is a common bovine aortic arch. This is how cows present with their arch, with a common trunk that arises into the innominate, the carotids, and the subclavian. Now, most patients don't have this in humans. It's more of the B or C type of variations, but you have this common trunk that's giving off to the innominate and the left carotid, and then the left subclavian being separate from that. And so these patients will only have 2 orifices in the arch. And the reason why it's important, because when we're fixing these pathologies, we're actually looking at this from the inside out. And so we need to figure out how many orifices there are before we start cutting and sewing. And that's why it's really critical that we have a preoperative imaging study, like a CT scan, to know, what the anatomy looks like. Now, going back to medical school, we all remember that the aorta is comprised of 3 layers, the intima, media, adventitia. Intima being a monolayered endothelial liner supported by loose connective tissue. The media being the thicker layer, as composed of almost 50 layers of fenestrated elastic fibers, interposed with collagenous, which is the strength fibers and the smooth muscle cells that basically allow for the distensibility and elasticity. And the adventitia is the outermost layer, which is a tough layer of colloid that basically provides the aorta with integrity. So what happens in a type A dissection or any type of aortic dissection is that there forms an intimal tear in the innermost layer, which is the intima, which allows the blood within the blood vessel to flow into the aortic wall, creating this false lumen that you can see in this diagram. And that false lumen can then tract proximally down to the aortic root, or it can go distally all the way down to the abdominal visceral vessels, or even to the legs down to the iliacs or the femorals. So that's what the dissection is. And I wrote here, most often the intimal tear occurs in the proximal thoracic aorta and propagate distally down to the descending and to the abdominal aorta. So we've come up with 2 classifications. One was from Dr. DeBakey, and he described his type 1 dissection as a dissection that arises in the ascending aorta, as you can see in this diagram, and dissecting down all the way down to the abdomen as type 1. If the tear originates in the ascending and remains in the ascending, you call it a type 2. And if the tear arises in the descending and went distally, you call it a type 3. Now, more commonly, we actually use the terminology Stanford type A or type B. Type A being any dissections that with the intimal tear occurring in the ascending, and type B, any dissection that occurs with the intimal tear in the descending. So that's kind of a more simpler classification than the terminology that we more commonly use. And for cardiac surgeons, it's kind of important to know because type A's usually mean it's an emergency surgery for us, whereas type B can possibly be managed medically. Now, this is a lecture about type A, but I just want to quickly go over type B dissections. As I said, most type B dissections are uncomplicated and can be managed with antihypertensive therapy with blood pressures in the 100s to 120s. You can use beta blockers, calcium channel blockers, nitroprusside, and basically keep these patients in the ICU for blood pressure control. And that is usually sufficient to care for these patients in the acute timing. Now, select population of these type B dissections are complicated, meaning some of the dissections can cause malperfusion of the abdominal vessels of the spinal cord, of the lower extremities, or it can lead to a rupture of the descending aorta itself. And this becomes a surgical or endovascular emergency where we might need our vascular surgeon colleagues' help to repair these. And these are a couple ways that type B dissections can cause malperfusion. The first one, you can see that, let's say that these side branches are the visceral vessels. You can see that the dissection can propagate and kind of pinch off those vessels, causing malperfusion. Or you can have a dynamic obstruction where you can have this intimal flap that flaps in and out of visceral vessel, causing intermittent malperfusion. So these are a couple ways where type B dissections can be emergent and might require some type of intervention, mostly by the vascular surgeons. But here I'd like to talk more about the type A dissection, and the reason why it's usually a surgical emergency, as you can see. It's mostly a surgical emergency because of the location over where the dissection takes place. And here's a diagram of, again, an intimal tear that occurred somewhere in the ascending or the arch. And because of where it is and where the dissection can propagate to, it can cause all these listed issues. If the dissection goes proximally down to the aortic root, you can see that it can dissect into the coronaries and can cause myocardial infarction. It can enlarge the aortic root itself and cause aortic regurgitation. Or if it frankly ruptures, it can cause a pericardial tamponade. If the dissection can propagate into the head vessels, then it can cause a stroke. And again, similar to the type B dissections, these dissections can propagate all the way down to the belly and cause distal malperfusions in the belly or into the limbs. And the signs and symptoms are related to exactly where those dissections take place. So if you have that dissection going down to the root and cause coronary issues, you can have chest pain. And in fact, 75% of the patients in type A present with chest pain, as opposed to 63% in type B. A lot of patients present with back pain, more so in type B than in type A. If the dissection propagates into the head vessel, or if it ruptures and causes pericardial tamponade, these patients can present with syncope. You might be able to hear a diastolic murmur if you have a large aortic regurgitation. And if that dissection propagates down to the belly, these patients can have abdominal pain. And if it propagates even further down to the limbs, you can have numbness and tingling of the lower extremities. They can have pulse deficits, as you can see. So what are the demographics and risk factors of these patients? Well, this comes from the IRAD database. So a lot of the data that I'm going to present come from the IRAD or the STS database. IRAD, or the International Registry of Aortic Dissection, is composed of about 20 centers of excellence that concentrate doing aortic work. And so that's where this database comes from. The STS is basically all cardiac surgery that's performed in our country. So it's actually a national database that we have, and most of the data come from those two. This one comes from the IRAD. You can see that the average age of these patients with type A are in their 60s. A lot of these patients present, they have connective tissue disorders like Marfan's, Ehlers-Danlos disease. They are mostly hypertensive. Almost 74% of these patients are hypertensive. And, a fair number of these patients have had previous cardiac surgery, because that is a risk factor for developing dissections down the line with all these suture lines in the ascending aorta that we create during this surgery. That could be a lead point to where the dissections occur. Now, I've compiled some data from our database. We've Dr. Zare and myself, we've only been here since June of 2019, so it's only less than 2 years worth of data, but we've done a fair amount. As you can see, we've done 32 cases so far, just in Harper. Mean age, pretty much similar, about 60 years of age, but differently from the national or IRAD database, we have a predominantly African-American population here, more than 50% are African-Americans. And again, majority are hypertensive, and we actually have a fair number who are diabetic, which is not really seen in the SDS or IRAD database. And this is a spread or demographic of where these patients have come to our hospital. You can see that the majority, about 20 patients, had come from the inner Detroit area. The 2 comes from the Huron Valley, where we have another hospital out there where these patients present. And then we have a spread of patients all the way up north to Port Huron, up to Lexington, and all the way out west to Albion, which is, I guess, closer to Lansing. So this is interesting, and it's really hard to believe for us cardiac thoracic surgeons, because I feel like every time we get a call about type A dissection, it's always in the middle of the night, 2 o'clock in the morning. But apparently, per the data, the IRAD database, significantly higher frequency of dissections occur from 6 to 12 p.m., with a peak between 8 and 9 a.m. And they significantly occur more in the winter time, with a peak in January. Now, how do we diagnose these in the emergency room? And this is where our colleagues in the emergency room and the IM department, these are the frontline physicians that come across these patients. With these patients coming in a lot of time with chest pain, back pain, they obviously get an EKG. Now, EKG is kind of a double-edged sword, because it kind of leads to the diagnosis of potentially coronary issues, and that may end up leading them to getting a left heart cath instead of getting a full body CTA for dissection, for diagnosis of dissection. So it can be frequently a double-edged sword. It can delay diagnosis because of that. And same goes with chest X-ray, because not all chest X-rays for type A dissections appear this way, as you can see in this diagram, where you have this widened mediastinum. A lot of the patients, over 20%, have normal X-rays. Now, a lot of the ED physicians and internal medicine physicians these days have these portable ultrasound devices now, and so a lot of them are pretty facile with it. They learn how to do a bedside echo in the chest and the belly, and so frequently our first call is by an ED doctor who's diagnosed the dissection based on ultrasound that they've done at the bedside. And you can see the diagram on the left, where you can see a intimal dissection flap in the ascending aorta. These are the aortic valves that you see here. This is the aortic root. And you can see the dissection flap that's formed, a clear indication that the patient has an aortic dissection in the ascending portion. Or these physicians might have applied the echo probe over the chest and seen a lot of effusions around the heart, evidence of pericardial effusion. But the gold standard really is a CT scan. And it is the initial diagnostic study in 69% of all type A dissections. And what's useful for us is not only the diagnosis of type A dissection, but it really helps us in operative planning, figuring out where we put all these big tubes in these vessels. And on patients who've already had heart surgeries in the past, it does help us to assess how stuck the heart is to the chest wall, how, to aid in our preoperative strategies. And then some patients, and we've had a patient recently where the diagnosis occurs in because the patient had chest pain, they go to the cath lab, they get a cath, and that's where they get diagnosed. And you can see a left heart cath from the groin and a dissection flap diagnosed that way. Again, this may delay diagnosis. This may cause further injury from all the instrumentations and catheters that are inserted up into the aortic root. and might cause contrast nephropathy as well. Now, what's the median time to diagnosis in the emergency room? It's been about 4.3 hours per the IRAS database. Delays more often occur in women, mainly because I think these patients present more with atypical symptoms. Patients with previous cardiac surgery also gets delayed diagnosis. And obviously the ones who are a little bit more sick, who are crashing, who are hypotensive, who are in tamponade, who have pulseless limbs or altered mental status, I guess they just get more attention, so they tend to get rapidly diagnosed. Now this is an interesting data showing the time from admission to OR interval. And you can see that, almost, I guess, up to 70% of the patients get diagnosed and sent to the OR within 6 hours, which is hard to believe, considering that the time to diagnosis was 4.3 hours, and the fact that a lot of the patients are already in the OR, in 3 hours time. It's hard for me to believe, but I think this might be due to the fact that a lot of the patients get diagnosed in one hospital and get transferred to another hospital, and the time from admission to that tertiary institution to the OR is almost rapid. The same goes with us. Once we hear the diagnosis type A dissection, we get them transferred to the operating room here directly, and so the time between admission to our hospital to the OR is almost immediate, less than that 1 hour. So this might be the reason why this is biased towards fewer hours. Now look at the survival curves. These are the Kaplan-Meier survival curves coming from the IRAS data comparing type B and type A. Survival is much better in type B and mostly, again, managed medically. Type A, less so. Now I want you to concentrate on the survival curves of just the type A dissections managed surgically versus non-surgical, or basically expectantly or medically. Now, as surgeons, I'm sure Dr. Zaire would agree that, since we were in medical school, we've been taught for type A dissections that their mortality rate goes up 2% every hour for the first, 48 hours, which means that, the patients would all be dead by 2 days, which, as you can see from this survival curve, is not true. You can see that the survival curve rapidly decreases and then reaches around 40% survival after about 20 days or so. Patients do much better with surgery. However, there's a lot of room for improvement, as the survival even after surgery is about 20%. Sorry, 80%, so 20% mortality rate. And this is a graph showing the survival of these patients and where, what these patients end up getting over the course of the time period between back in the 90s to 2010 to 2013. And you can see that more and more patients are being managed surgically. As you can see, back in the 90s, about less than 80% were managed surgically. Now 90% are managed surgically. Less and less patients are actually being managed medically. Mortality rate overall has really kind of ranged between 30 to 20%. But if you look down carefully down below, those of the patients who are managed basically non-surgically, their mortality rate has been anywhere from 50 to 60%, which hasn't changed over the course of the years. However, surgical mortality has come down. Back in the 90s, it was in the 25% range. Now it's come down to 18 to 20% range. And here's our data, where our mortality rate over the those cases that we've done since we came in 2019 is around 21%. So really not too different from the IRAD database. And again, IRAD is coming from all these aortic centers of excellence throughout the world, actually, not just this country. And so it's not, or our mortality rate is not so different. And this is an interesting graph of all the centers, the hospitals that perform type A dissections on the x-axis, with the number of cases that each of those centers have performed. So you can see that there are very few centers in this country that have done, more than 25 cases. And majority, as you can see, the median dissection repair per center is only 3 in this country. And only 11% of the centers, or 72 centers in this country, have performed more than 10 cases. How many have we done in 2020? We have done 22 cases. So we're not doing shabby in terms of the number of cases that we have performed in this country. Now, this is where the fun begins. This is what we get to do in the OR.
Okay, can I interrupt? I just want to talk a little, I just want to clarify for the audience a little bit as to which patients are medically managed. I think it's not quite clear to everybody why they're medically managed. If you could comment on that a little bit.
Sure. I think the patients who are medically managed are the ones that the surgeons end up deciding that they are not surgical candidates.
Exactly.
I'm not sure if you agree with that.
No, I agree 100%. That's what I wanted you to say.
The patients who are, we deem too elderly or too fragile to be able to tolerate a big open heart surgery are the ones that end up in the medically managed arm. Do you agree?
Yeah, I agree exactly. I think it's important to stress that is that still the prevailing overall agreement among surgeons is that the patients have their best chance if they can be surgically managed, because it's really iffy what the medical course is going to be without surgical management. And while it may not be as bad as 2% per hour for the first 2 days, it's probably at least 1% per hour for the first 2 days. And so your risk benefit there then becomes a risk of, in all comers, a risk of 20% mortality with surgery or 50% mortality without surgery. So still the risk benefit is 30 percentage points on the side of surgery in all comers. And I think, it's also, if you dive deep into the data, you can look at various subgroups. Like if you look at, there's on the East Coast, the University of Pennsylvania has extensive experience, and they, in some of their publications, have teased out those patients that have presented with neurological complications as a presenting symptoms in conjunction with everything else. And those patients had fairly high mortalities, whereas if they, in the group, if you take out all the patients that presented with neurological complications, they had mortalities in single digits in those patients. So it's very important to get these patients before their extensive dissections and before their complications and malperfusion and all of that, because that contributes significantly to their mortalities, their perioperative mortality.
That's absolutely true. All right, so now we get to go to the operating room and discuss what we do. And I don't put this slide up, in jest, but it's, partially true in the sense that, type A dissection repair, as you can see, the surgical mortality rate is 20%. That is really high. And so, as surgeons, I think, we go into the OR, with a little bit of angst, knowing that, not everybody that we're going to operate, is going to survive. And, just a quick overview about heart surgery. I put this Heart Surgery 101, not so that you need to learn exactly what this diagram shows. It doesn't have to be this complicated. This is just a diagram about what a heart and lung machine is. But heart and lung bypass machine is, simply put, a large venous drainage cannula on the right side or the blue side of the body. So on the venous side of the body to drain the blood, and that venous blood gets oxygenated outside of the body, and then it gets injected by another cannula that goes into the red side or the arterial side of the body. So that's all you need to know about heart and lung machine or bypass machine, is that there's a venous drainage side and arterial reinfusion side. Now, there are different strategies to where we put these tubes into the arterial side. This first diagram shows a cannula that's in the axillary artery via subclavian cut-down approach. And this is how in this situation, the patient is getting oxygenated blood perfused. Here is a cut down into the groin with a cannula into the femoral artery. And this is how, in this situation, the blood is being perfused. And in a dissected patient, and this is something that I think Dr. Zare and I perform the most, is we cannulate centrally, meaning we stick a needle into, and we have to make sure that this needle goes into the true lumen of the aorta, not the false lumen, because you can imagine if we stick the cannula into the false lumen, we're going to be injecting high flow blood into the false lumen and causing the false lumen to get bigger and worse. So we have to make sure that the needle ends up in the true lumen, and then using cell digital technique, get the cannula into the true lumen. So that's yet another approach of how we can cannulate the red side or the arterial side of the heart.
Dr. Asaki, how do you make sure you are in the true lumen? Do you have a furrow or angio?
Yeah, absolutely. So the good question. So for the last diagram is what Dr. Alvarez is asking, how we make sure that the needle ends up in the true lumen. Twofold. One is by transesophageal echo guidance. So in every open heart surgery cases, including dissection repairs, we always have the cardiac anesthesiologist have a transesophageal echo placed. And so with that, we can make sure that the needle tip, as well as the wires that we insert through the needle, ends up in the true lumen. And then, part of it is also feel, because you can, when you go through two layers, you can actually feel two kind of resistance, when you poke into the false lumen first and then to the true lumen. So it's also a feel thing as well. But, mostly basically transesophageal guidance, getting that needle into that true lumen. And as you can see from the SDS database, different surgeons have different approaches and different ways that they want to cannulate. A lot of the surgeons actually like to cannulate through the groin, through the femoral artery. And then about a quarter of surgeons like to go through the axillary artery. And then a fifth like to go centrally like we do. And then a lot of surgeons like to do combinations of one or the other. Now, I'm not sure if you've seen or heard of what a cross clamp is, but this is a cardiac surgeon's best friend. And this is what we use for all open heart surgery, and we rely on it. So as you can see this diagram, this patient has a venous drainage cannula on the right side of the heart, and you have a aortic reinfusion cannula in the aortic arch. And then when we're ready to do the open heart surgery, we basically apply this big honking clamp across the ascending aorta. And this prevents most of the blood in the heart to go through the heart, most of the blood to go through the heart. And therefore we can open up different parts of the heart to do open heart surgery or valve surgery or coronary, surgery. So that's kind of the basics of open heart surgery. However, in a dissected ascending aorta, as you can see here, you can see how thinned out the aorta is now. You can see a film of basically blood in the false lumen and how fragile it looks. You cannot cross clamp this kind of aorta, because once you do, you can rupture it and then it's game over, right? Or you can see this is the same patient. This is the specimen of the ascending aorta that we have taken out. You can see a clot of blood already in the false lumen. So you can imagine if you apply a cross clamp across this aorta, some of that clotted blood can go up into the brain and cause a stroke. So the best cardiac surgeon's best friend, the cross clamp, cannot be used in an aortic dissection case. So what do we do about that? Well, not sure if you guys have seen Austin Powers, their initial movie, where Austin Powers was basically frozen in time for like 20 years before he's woken up. But what we do in the OR is not too dissimilar to what Austin Powers went through. So what our forefathers in cardiac surgery have come up with is, why don't we cool down the body down to a certain temperature? And you can see that as you cool down the body temperature, the cerebral as well as the systemic metabolic rate goes way down. And with that, we can kind of buy time to drain the whole body of blood and be able to just cut open the aorta without having blood in our face. And you can see this graph showing as you go down in temperature, the metabolic rate goes down, and the time that we have to safely conduct what's called deep hypothermic circulatory arrest goes up. And so by going down to about, we usually go down, a lot of surgeons like to go down to 18 degrees Celsius. It gives us about 25, 30 minutes, of circulatory arrest time where we can drain the patient's blood out of the body and safely conduct the surgery without having blood in our face. And this is from the SAS database showing how low the surgeons like to go during the circulatory arrest time. And as you can see, 18 is really the magic number. This is where a quarter of the surgeons like to go down to. And with that, as we said, the blood is out of the body, so we can not have to use a cross clamp and just open up the aorta, cut out the portion of the intimal tear, and sew on a graft, as you can see here. And once we sew on the graft to the descending anastomosis, or this is the proximal arch, then we can cross clamp the graft and start rewarming the patient back to normal body temperature and finish the rest of the case. The rest of the case, meaning this is the completed supracoronary tube placement, which is the simplest type of surgery that we do for dissection, where the distal anastomosis is here and the proximal anastomosis is here. And proximally, sometimes the dissection has really injured the root of the aorta, where we have to do what's called a Bentall, where we have to take the coronary arteries as a button off of the root, and then basically exchange the valve with a mechanical or a tissue valve, put a graft on it, and then sew on the coronary buttons to that graft, and that's called a Bentall or aortic root replacement. Now, sometimes, especially in connective tissue disorder patients like Marfan's, where the patients are young and the valves, leaflets themselves are intact, you can do an even more complex operation where we preserve the valve leaflets and basically put a tube graft over on top, and then sew the leaflets into the graft, and then sew the buttons onto the graft. So it's a much more complex operation in the root, which is more commonly done in again, younger patients that we want to preserve the leaflets for. Now, let's go back to the distal anastomosis, where what we've done in the aortic arch. So the supracoronary graft, which you saw earlier, is the simplest one, but sometimes the dissections can go way past the ascending aorta. It can go down to the arch, it can go down to the descending, and that tear has to be excluded during the operation. And so then you might have to do a more complex aortic operation like you see here. And in this situation, sorry, I forgot to mention that, I think I did mention that you only have about 30 minutes during a circulatory arrest time where you can drain the patient of blood, right? You can imagine if you do a more complex aortic repair like this, you need a little bit more than 30 minutes. So what do we do about that? Well, there are a couple things that we can do. So depending on where we put that cannula into the arterial side, we can do what's called antegrade cerebral protection or retrograde cerebral protection. In this case, the cannula is in the axillary artery. And if we clamp the base of the innominate artery, you can imagine that while during circulatory arrest, we can actually be flowing blood, oxygenated blood, down the axillary artery, up into the carotid, into the brain, so that we can continue to oxygenate the brain during the circulatory arrest time. So that's called antegrade because that's going the direction where it's supposed to. Well, you can do it the opposite direction. Some surgeons, Dr. Zen and myself, I think we both like to do this during dissections, is we can put a cannula in the SVC, and then we can flow similarly oxygenated blood up the SVC towards the venous side of the brain. So it's backwards. So we sometimes call it the enema, brain enema, because we're basically injecting blood backwards. But this has also shown to adequately cool the brain and give us a little bit more time during the circulatory rest time to do more complex aortic work. And you can see, this is from the STS database, that most surgeons utilize either antegrade or retrograde cerebral protection, about 23% antegrade, about 20% retrograde. And then some, about a third of them actually do not use either, and they just go down, cool them down, and hope that the 30 minutes to 40 minutes that they have is adequate to do that distal anastomosis. But once you have that protection and more time, it buys us time to do more complex work in the aortic arch. And this is a case that Dr. Zare and I did back at Hopkins. And you can see that this takes way more than 30 minutes. And we were able to do this because we had antegrade cerebral protection during this time. Now, so what, I think we touched base a little bit about the predictors of mortality. Patients who present in shock or tamponade who are crashing obviously do poorly per the IRAD database, about a 2.69 odds ratio. The patient who present with basically propagation to the belly with mesenteric ischemia, with lactemia, septic shock, these patients do horribly. As you can see, the odds ratio is 9 there. Again, patients who have pulseless limbs, basically suggesting that the dissection had propagated all the way down to the leg, they also do poorly as well. So the take-home message is that, type A dissection is still a disease associated with very high mortality. Even though we've gotten better over the last, 2 decades or so, the mortality rate is, anywhere from 18 to, 25%, even after surgery. And without surgery, again, 60% mortality. And this is where, again, we rely on the ER doctors, the IM doctors, really to perform a timely diagnosis, because that leads to getting these patients, quicker to the OR and getting them repaired surgically. And as you can see, it's a pretty technical surgery that requires a lot of preoperative planning, and that is why we harp on, wanting a preoperative CT scan. Even if the diagnosis is made on ultrasound, we still want a CT scan so that we know where to put those big cannulas in, so that we don't cause, worsening of the dissections. And that's why the CT scan is so critical. And even though we have these data suggesting that one reason or another, hypertension, age, leads to higher mortality, I think it really depends on us evaluating the patient on a patient-by-patient basis, because we've had a patient like this who was 86, who underwent a successful type A dissection repair and survived, and and is living a happy life now. So I want to end my presentation there. Thank you.
Thank you so much, Dr. Terasaki. It's a great presentation. There's a few questions comes. If you want to stop sharing your screen. A few questions comes which is challenging for us. I mean, there's one question coming from the audience. If a patient presents with tamponade and shock in a place without CT surgeon on site, is there any benefit in performing a quick pericardiocentesis to stabilize them until they get transferred to an OR?
I believe so. If they have the capability of either having a cardiologist or even the emergency room doctors place a catheter in the pericardial sac and relieving that pressure, and I think that will buy us time, for the patient to come to a tertiary center for adequate surgery. Now, if it's a complete frank rupture into the pericardial sac, I'm not sure if that's necessarily going to help the cause. But for most patients, I think a lot of this fluid around the pericardial sac is not due to frank rupture, but it's mostly from this inflammatory process that's going to the chest. And so what the draining of that does is it kind of just relieves the tamponade, brings up the blood pressure, and buys us some time for them to reach another institution. Dr. Zare, what do you think?
Yeah, I 100% agree. It's interesting if you've done a lot of dissections. A fair portion of them will have pressure under, or will have fluid under pressure in the pericardium. So like some degree of tamponade. And invariably, it's always leaking from the same place. It leaks from the place between the aortopulmonary window. That's where most of the staining occurs and the thrombus within the wall and very, very few, frankly, rupture, but they still will die of a pericardial tamponade. So we can see that when we open up the chest, we can see that the pericardium's tense and we can see that it's under pressure. And what we often do when we're opening that patient's pericardium, we'll tell the anesthesiologist who's been having the patient on, maybe even on inotropes to keep the patient's pressure higher, we're going to say, we're about to relieve the tamponade. So watch your pressures, they're going to go up dramatically. We make a small hole, the blood juts out. And once you clear it away, there's no active bleeding. So I think you're exactly right that if you relieve that tamponade, in an outpatient's, or I mean in an ER setting at another hospital, very high chances are that patient's not going to die, but they're going to improve enough that you can get them to a center.
Other question is, we saw in the map that you are getting referrals from other centers and the transfer is different either by air or ground. How come they can reach your team? I know there's a code aorta, a number, but what is the number that's used for people, let's say ER in Northern Michigan or Mid-Michigan would like to transfer a patient? Is there a certain code or number they can call directly?
I think it's the number to the transfer center at the DMC. I don't have the number off the top of my head, but if you can reach the transfer center at DMC, they're really good at reaching one of us cardiothoracic surgeons on call, and we would usually accept the patient. And from there, it depends on the weather condition. It depends on the distance, whether or not the patient would be transported here by land or by air.
Great.
The DMC transfer number is 313-578-6767, and this will be this video conference will be publicized, so that will be out there. Yes, or the other option is to call, if you don't know the number, is just ask for the cardiac surgical attending on call, and that will transfer you to somebody directly that will give you the person to discuss the patient with. And I did want to emphasize, Yusuke said it before, but I want to emphasize it again, is that these patients we operate on patient by selection, and it does us worlds of good to lay eyes on the patient. We don't, as he showed earlier in his presentation, Dr. Michael DeBakey got his dissection repaired at 97 years of age and lived. Yusuke did his recent patient that was 86 and did very, very well. So there are patients in the elderly age group that we will not hesitate to operate on if they're limited with their comorbidities and if they don't present with other complicating things like malperfusion or neurological deficit at the time of surgery. So we really like to transfer everybody in with a type A dissection so we can personally assess them.
Great. Another question comes up is, thank you, Dr. Zare and Dr. Saki, for discussing the topic. How's the line of management be for a patient with type A dissection who has already developed some cerebral malperfusion in terms of cannulation strategy, brain protection, and also preoperative imaging?
Well, this is where a CT scan would help, but presumably if the patient is already having neurological symptoms, the dissection flap had extended into one of the head vessels. And so in that situation, cannulating the axillary artery, for example, is probably not the best solution because that might propagate the dissection in the head vessel, and you might want to stay away from that and go to the legs, or you can cannulate centrally like we commonly do. So that's something. But again, looking at the CT scan will allow us to decide whether that is the best decision or not. And without that CT scan, it's hard to make that call.
Yeah, and this is where the experience helps, and just seeing things from the inside. So frequently it's not infrequent to have stuttering neurological symptoms, so that they're weak on one side and then not, and then weak and then not. And that's probably some kind of a dynamic flap at the origin of the carotid vessel or the innominate, in which case, when we're on the inside, we can see how well we're going to be able to reperfuse. And often it's just as simple as cutting away that minor flap at the base of the carotid or the base of the innominate, and then you're left, when you reconstruct, with perfusing up both channels when you're done with that reconstruction. Sometimes it requires actually doing branch vessels to the head, like you saw in that case that Dr. Terasaki and I had done, where we did branch vessels to every vessel that comes off the arch with that kind of maze type reconstruction. That's a complicated dissection repair where you have to replace everything because you think you're going to end up with brain malperfusion at the end. So these are subtleties of each individual case, which require a transfusion, which require a preoperative CT scan to evaluate.
All right, perfect. I have other questions coming from early in the presentation. You mentioned about the delay in discovering a diagnosis, and this comes we need more awareness as cardiologists and emergency department, is that dissection should be always on the radar. But and there is something called the triple rule out, the PE, the CTA for the dissection, and but what is the triggers will be? What are the red flags for ER physician, as well as cardiologist, receiving a call for chest pain for a patient that's highly suspicious for dissection?
Well, Chadi, I think that the pain syndrome tends to be a little bit different with a dissection than it does with an acute MI. I can't say that for sure, but pretty much every patient that has a type A dissection says, I experienced the worst pain I have ever had in my life, and it bore through to my back. And even those with migrating dissections down, then they'll say, then it's settled in my belly, say if there's a type B component. So and frequently those patients will have not had chest pain syndromes before. So, the history of hypertension is very, very important. In a hypertensive patient that gives you that story, you're likely to start thinking dissection. Now, the thing that complicates it all, as you well know, is that somewhere between 15% and a quarter of type A dissections present with EKG changes. And those are the patients that probably have some kind of osteocoronary involvement. And that is very, very difficult to sort out. And those are the patients that end up in the cath lab. Now, remember, we didn't have CT scan back in a day, and the majority of type A dissections ended up diagnosed in the cath lab. That was the gold standard for type A dissection diagnosis, was actually catheterizing the patient. Now it's kind of frowned upon, as like you somehow missed it if you end up in the cath lab and end up with a diagnosis. You say, whoa, wait a minute, we should have diagnosed this with CT. So I'm trying to say it's not the end of the world to make a diagnosis in the cath lab. And you may even have your coronary shot, which is an additional benefit to know what your coronaries look like heading into a type A dissection repair, which we frequently don't have now because we rush them to surgery. So, I think in the ER, a very close history, what is the pain syndrome, in conjunction with the subtle findings you see on chest x-ray, and there can be a number of those with the EKG, makes you wonder whether or not you should get the CT scan first.
And I also think that ultrasound is a big game changer, in that it's not just a big machine that's being that the emergency department only has one or two of these days. There's a lot of portable ultrasound machines that the physicians carry around, and you can just apply the ultrasound on the chest, and they can potentially see a dissection flap in the ascending aorta much quicker than even a CTA or a cath or any other diagnostic procedure. So
we have 3 minutes left. Just a quick comments that the transfer line for the DMC for a code aorta or any emergency is posted on the screen now. Question coming, maybe this is the last question, and then we'll close, is have you seen any cases of aortic type A dissection where the patient have or had an MI during or before the diagnosis of aortic dissection, and which one you would treat first, or how would you treat that case?
Sorry, can you repeat that one more time?
So you have a case where a patient coming with acute myocardial infarction or a dissection propagating into the RCA or left main. Have you seen a case before, and how would you treat that patient?
Well,
I've dealt with that.
I've seen a patient that ended up as a mortality for me, which when I took off the cross clamp time, the blood was jetting out the left anterior descending. So they had actually dissected all the way down through the left main into the LAD, and then when the cross clamp was released, that ruptured into the, outside of the heart. And that patient ended up a mortality. So indeed, you can have complex dissections which have occurred. But the patients that you have problems with when you take off the cross clamp and the heart doesn't recover well, you can sometimes feel calcium. You can sometimes feel issues there. And it is not infrequent where we do empiric grafts on some of those patients. We take vein out and we then go and graft that patient. I had one recently, I had to do that with the right coronary artery because it had dissected down the right. We came off, the right heart wasn't working very well, took a piece of vein, empirically put a vein graft on, and the lady did fine. That was here at Harper University Hospital. So I think, we kind of play these things by ear because frequently these patients don't have a coronary angiogram prior to taking them to surgery because of the risk of them passing away on the table getting an angiogram. So generally we don't get angiograms, but it's well to point out that it's precisely these patients that are at risk for coronary artery disease as well, because they're hypertensive. And that's, so they're at risk for having had coronary disease in their life that they just don't know about.
That's perfect. With that, I would like to close the program. I would like to thank first Dr. Terasaki for a wonderful presentation. We have a wonderful comment coming also from Linda from Britain, that she is actually asking to have a recording of the session, which we are, and will be posted on the DMC YouTube channel under DMC Medical Group. Thank you, Linda, for that nice comment. And thanks for all the participants who asked great questions, was very engaging, and Dr. Terasaki for your time, and Dr. Zara for valuable and expert input on this topic. Please watch this video and others on DMC Medical Group YouTube channel. I would like to give a shout out to Elise Bennett. She is our DMC Medical Group marketing queen. She is the one behind the scene who's putting all these programs together, and she is the one who's hosting these on YouTube. So next month, we're going to have Dr. Mocano speaking about primitive cardiology and how not to get into cardiac problems. Please stay tuned, and this is going to be on the last Thursday of the month of May. Thank you, Dr. Terasaki, Dr. Zara, for your time, and for the audience. Till next time, please be safe. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.